Hello everyone. In this video, I'm going to discuss about some anemias that occur due to RBC enzyme deficiencies. So first we'll start with the G6PD deficiency. Remember, this is the most common RBC enzyme defect that will cause hemolytic anemia. Okay, so this is the most common RBC enzyme defect that will cause hemolytic anemia, and the inheritance pattern is X-linked recessive. That means it is found mostly in males. Rarely it can be found in females if there is unfavorable ionization of the active X chromosome, but usually it is found in the males. Okay. Now let us understand the pathogenesis of this G6PD deficiency. We have discussed previously that there are three important pathways that RBC uses very efficiently. Those three pathways are: first pathway we discussed, that is HMP shunt pathway or hexose monophosphate shunt pathway. The second pathway we discussed about the methemoglobin reductase pathway, and the third pathway was Leuering-Rappaport pathway. Okay, so G6PD, glucose 6-phosphate dehydrogenase, this has role in the pentose phosphate pathway or the hexose monophosphate shunt pathway. So what happens in this pathway? In this pathway, glucose will be converted to glucose 6-phosphate, and then this glucose 6-phosphate will be converted to 6-phosphogluconate with the help of the enzyme G6PD. By this process, they will convert the NADP to NADPH. Okay, so there will be production of NADPH. Now, this NADPH will convert oxidized glutathione to reduced glutathione. And why reduced glutathione is required? Reduced glutathione will convert this reactive hydrogen peroxide to water. So hydrogen peroxide, if it is not metabolized to water, it can cause production of reactive oxygen species, and that will cause further damage to the tissues. Now, this reactive oxygen species, this hydrogen peroxide, it can be formed because of infections, some oxidant stress like drugs, and some food items. But the most common cause is infection. The most common cause to produce the oxidative stress leading to hemolysis in G6PD deficient individuals is infection. Among the drugs, important drugs are primaquine, chloroquine, which are used as antimalarial drugs, and also sulfa drugs. There are various other drugs also, but these are the important ones. It was first identified in patients who have received primaquine. And among the food items, fava beans are classically known to cause hemolysis in G6PD individuals. Now, how this oxidative stress in these individuals is causing hemolysis, that we'll discuss in the next slide. Let us first discuss about the various classes of G6PD deficiencies. Now, according to WHO, it is divided into 5 classes: 1, 2, 3, 4, 5. But remember, this 4 and 5, here the enzyme is not deficient. That means 4 and 5 are actually normal. They are normal. In class 4, the enzyme activity is more than 100%, and in class 5, enzyme activity is more than 150. So that means they will not have any clinical manifestations. This normal variant, the class 4 normal variant, is otherwise known as the G6PD B variant. G6PD B variant, this is otherwise known as the wild type of G6PD variant. Then what is the class 3? Class 3 is when the enzyme activity is 10 to 60%. Okay, if the enzyme activity is 10 to 60%, that is class 3. And the example is G6PD A minus variant. G6PD A minus variant. Class 2, example is G6PD Mediterranean variant. This one is common in India, G6PD Mediterranean variant. Here the enzyme level is 2 to 10%. And the class 1 is the most severe one, where the enzyme activity is less than 2%. However, it is rare. And this can cause chronic hemolysis. Sometimes it is described as chronic non-spirocytic hemolytic anemia. So if the enzyme activity is less than 2%, which is known as the class 1 G6PD deficiency, here these patients will have chronic hemolysis. But the common variants, that is the class 2 and class 3, they will cause episodic hemolysis. They will cause episodic hemolysis. Episodic hemolysis. Why? Because only when there is oxidative stress, they will cause hemolysis. If oxidative stress is not there, there will be no problem to the RBCs. Okay. So G6PD Mediterranean means from the name itself, you can understand these are common in the Middle East. Okay. So in which areas the G6PD is common? So basically, G6PD is common in those areas where malaria is endemic. Where the malaria is endemic. So many of these hemolytic anemias, we'll also discuss in sickle cell disease, we'll also discuss in thalassemia. These cases, these are usually common in those areas where the malaria is endemic, because these variants, these types of RBC abnormalities, they give a selective advantage against this infection, against the malaria. So that is why this is common in those areas. Now we'll understand the pathogenesis of G6PD deficiency. So what happens when there is a young RBC? Young RBCs, they will have good amount of G6PD enzyme. So young RBCs are usually not affected. But once the RBC will spend some time in circulation, there will be reduced activity of glucose 6-phosphate if it is already a G6PD deficient variant. So if this RBC is having G6PD deficiency, whenever there is oxidative stress, if there is oxidative stress, it will cause cross-linking of the sulfhydryl groups which are present on the globin chains. So these are the globin chains. These are globin chains. And in presence of oxidative stress, these sulfhydryl groups will become reactive. They will have the sulfhydryl groups. It will become reactive. And if the patient has deficient enzyme, there will be cross-linking. There will be cross-linking of the sulfhydryl groups. Now that will cause denaturation of the globin chains, and these denatured globins can accumulate. It can precipitate like this. These are known as the Heinz bodies. These are known as the Heinz bodies. Okay, so the denatured globins, they will accumulate. They will precipitate on the membrane of the RBC, and these are known as the Heinz bodies. Now these Heinz bodies can be demonstrated by using supravital strain. The most commonly used one is the crystal violet strain. Crystal violet strain. As you can see here, as you can see, these are the RBC, and you can see there is a Heinz body here. You can also appreciate there is Heinz body here, here. Okay, so these are the multiple Heinz bodies. These are nothing but the denatured globin chains, and you can demonstrate them with supravital strain like crystal violet. Okay. Now accumulation of these Heinz bodies over the cell membrane will it can cause membrane damage, and whenever there is severe membrane damage, whenever the membrane damage is severe, it can cause intravascular hemolysis. It can cause intravascular hemolysis. So in classical case scenario, the patients, after taking primaquine, for example, if the patient has been given primaquine, after taking the drug, if the patient is G6PD deficient, he will develop this intravascular hemolysis 2 to 3 days after taking the drug. 2 to 3 days after the drug intake, and intravascular hemolysis will manifest as hemoglobinuria and hemocysteinuria. So these patients will have reddish urine. Okay, so they will present with reddish urine. Now, but what happens whenever the membrane damage is less severe? If the membrane damage is less severe, there will not be intravascular hemolysis, but rather there will be extravascular hemolysis. So what happens if the membrane damage is less severe? When these RBCs pass through the splenic pass through the splenic sinusoids, these Heinz bodies can be removed by the splenic macrophages. The splenic macrophage, they will try to remove these Heinz bodies. And in this process, they can produce a type of RBC that is known as the bite cells, because the RBC is bitten by the splenic macrophages. So they will produce bites. They will produce bite cells. So these are the bite cells. That means a portion of the membrane has been taken out by the splenic macrophages. And because they take the membranes, similarly, what we have discussed for heritage spherocytosis, the reduction in the membrane amount can cause formation of spherocyte. Okay, so they can also form spherocytes. Okay, so if the membrane damage is severe, they will cause intravascular hemolysis. If it is less severe, when they pass through the spleen, the splenic macrophages will take a chunk of the RBC, which is containing the Heinz body, and it can form bite cells, it can form spherocytes. Now, bite cells and spherocytes, they are less deformable, and ultimately they will end up in extravascular hemolysis. They will end up in extravascular hemolysis. So G6PD deficiency is a condition which will have both intravascular hemolysis and extravascular hemolysis. But what is interesting to understand is these are all episodic. I mean, most of the cases are episodic. That's why the features of chronic hemolysis are absent. Features of chronic hemolysis are absent. What is the feature of chronic hemolysis? For example, if the extravascular hemolysis is happening for a longer time, these patients should have, I mean, whenever the extravascular hemolysis happens for a longer time, there will be splenomegaly and gallstones. But in G6PD deficiency, you are not going to see those things because it is episodic hemolysis. Similarly, intravascular hemolysis, if it is happening persistently, that can land up in iron deficiency. But that is unusual in this case because it is episodic. Okay, so it is episodic. And if you see the bite cell, you can appreciate here. So this is the bite cell. This portion of the RBC has been taken by the splenic macrophages. Okay, so Heinz bodies are demonstrated by supravital strain like extraviolet, and this is the normal Jimson strain which is showing the bite cells. Okay, so this is all about the G6PD deficiency. Now there are two more enzyme deficiencies I want to discuss. Pyruvate kinase deficiency. Now you have to remember that pyruvate kinase deficiency is the most common glycolytic pathway enzyme defect, most common glycolytic pathway enzyme defect that can cause hemolytic anemia. Okay, so you have to read the question carefully. Many times they ask what is the most common glycolytic pathway enzyme defect that can cause hemolytic anemia. Yes, hemolytic anemia, and we tend to answer G6PD deficiency, but that is not the answer. If they ask you about the glycolytic pathway, it is the pyruvate kinase. Glucose-6-phosphate dehydrogenase is not a glycolytic pathway enzyme, it's an enzyme for hexose monophosphate shunt pathway or the pentose phosphate pathway. Now, what happens in pyruvate kinase deficiency? So basically, if pyruvate kinase is not there, the phosphoenol pyruvate cannot be converted to pyruvate. And this is the process where the ATP is getting generated. Okay, so this is a step in the glycolysis, and in this step, the ATP is getting generated. So if the patient doesn't have pyruvate kinase, there will be decreased ATP production, and this decreased ATP production can cause RBC damage leading to hemolysis. Okay, but there is one more point you need to understand. If the pyruvate kinase is not present, there will be accumulation of the previous intermediates, like 1,3-bisphosphoglycerate. If this accumulates, it will try to get converted to 2,3-bisphosphoglycerate through the Leuering-Rapoport shunt. Okay, so whenever pyruvate kinase is not present, there will be accumulation of phosphoenol pyruvate that will cause further accumulation of previous intermediates like 1,3-bisphosphoglycerate. If 1,3-bisphosphoglycerate is there, it may be converted to 2,3-BPG, and 2,3-BPG. What is the function of 2,3-BPG? It will cause rightward shifting of the oxygen dissociation curve. That means it will reduce the oxygen affinity of the hemoglobins. So there will be more oxygen delivery to the tissues. Now, this is good or bad? This is good. This is what we want. We want oxygen to be delivered to the tissues. So that is why patients with pyruvate kinase deficiency may have a lesser degree or lesser severity of hemolytic anemia because they can cause increased 2,3-BPG, which will cause increased oxygen delivery to the tissues. Okay, so severity of the anemia will clinical severity of the anemia will be reduced because there will be good amount of oxygen delivery to the tissues. Usually these present with neonatal jaundice, and also they will have splenomegaly because here there will be chronic hemolysis, so they will have splenomegaly. Usually they will also present with neonatal jaundice, but the severity of the anemia is somewhat lessened by the increased 2,3-BPG. In peripheral smear, you will get echinocytes. So in this condition, you are going to get echinocytes. What are these echinocytes? These are otherwise known as the Burr cells. So basically, there will be surface projections, as you can see here, as you can see in this RBC. Here also you can see there will be even surface projections. Okay, so these surface projections are evenly distributed. These are the echinocytes. Okay, so reduction in ATP will cause some kind of membrane abnormalities that will cause this even regular surface projections. Those are known as the echinocytes. We'll also discuss later about the acanthocytes or the spur cells. In acanthocytes, you will get irregular, uneven, spiky projections. But in echinocytes, you will get regular, even projections. Small projections. Okay. But this is not specific for pyruvate kinase deficiency. This can also be found in end stage renal disease, that means chronic kidney disease. Sometimes it is also found in liver disease. Okay. And this can also be seen as a slide artifact. Slide artifact. I mean, if you process the sample late or if you prepare the smear late, I mean, after a long time after taking the sample, if you're processing it for the peripheral smear, you may get this appearance. Okay, so this is about the pyruvate kinase deficiency. Now we'll discuss about the last one, that is the pyrimidine 5' nucleotidase deficiency. Now remember, this is the third most common enzyme defect. RBC enzyme defect that can cause hemolytic anemias. So the most common cause is G6PD deficiency. Second most common cause is pyruvate kinase deficiency. Okay, so pyruvate kinase deficiency is the overall second most common cause. But if they ask you what is the most common cause in glycolytic pathway, answer is pyruvate kinase deficiency. Overall, third most common cause is pyrimidine 5' nucleotidase deficiency. This is just a spotter question you have to answer. So a very peculiar finding you will get here. As you can see, there is bluish dots over the RBCs. These are known as the basophilic stippling. Basophilic stippling. So pyrimidine 5' nucleotidase, if this enzyme is deficient, there will be abnormal accumulation of RNAs, increase RNA accumulation, and this will give the appearance of basophilic stippling. Okay, so RNA metabolism. I mean, for the metabolism of RNA, we need this enzyme, and if it is not present, there will be abnormal RNA accumulation that will lead to formation of this basophilic stippling. Again, this is not specific for this condition. It can also be found in lead poisoning. I mean, lead can also inhibit this enzyme and can cause basophilic stippling. It is also found in alcohol toxicity and various conditions of ineffective erythropoiesis like thalassemia and sickle cell disease. So in all these conditions, you will also get basophilic stippling, and sometimes in sideroblastic anemia also you will also get basophilic stippling. So that's all about the enzyme deficiencies causing hemolytic anemia.